over the next 45 minutes, we can talk about what we want, but I'm really excited actually about sharing what you've been working on, and it's on this topic: can we make machine learning of routine health data more explainable and trustworthy? Which is really a problem that I've tasked Flavio with for working through with kidney health data, and we've been talking about this quite a lot in kidney health data because kidney disease has been one of the exemplar topics that Google DeepMind have been working in trying to maximize the use of big data to predict health outcomes and improve care. So what I was hoping to do is just maybe give no more than maybe 5 or 10 minutes just to explain a little bit about the clinical background of the problem. And then Flavio, it's all yours for the science bit. I will have no science and no renal physiology. It'll just be a little bit of clinical background. So Flavio, this is you. So it's really nice to have you calling in from Brazil. And we've been in touch for over a year now, but you've had access to some kidney health data over the last maybe 4 or 5 months. Would that be about right? I'm working through this problem. So Flavio's background is in computing science and artificial intelligence. His PhD is really interesting with its title, Automated Reasoning with Uncertainties, which I think captures still what you're kind of working in, but well beyond the breadth of just focusing on healthcare. It looks like you've done lots of really interesting stuff in all sorts of different environments. And we were in contact with Flavio and a number of folk from his team through an Academy of Medical Sciences networking grant, which was really enlightening in how healthcare happens in Brazil and also in kind of research. And this is one of the products is that we've had an opportunity to now work together on a clinical problem. So the clinical problem is really about decision support, which I would think of as being an umbrella of a number of different aspects in the way IT can assist healthcare providers to do things either better or make safer decisions. And part of this comes from the fact that a lot of the decisions happen not just by experts in their field, but often by non-experts, both at levels of triaging, but also just in day-to-day practice, often by people that are seeing large numbers of people, and there's always risk of lapses or blind spots in care. And just broadly, if we think of kind of 2 different groups, so there are, to some extent, less complex in terms of the modelling, but flags or nudges that can be embedded in IT that help people do things a wee bit more safely. So for instance, here is an example from a GP terminal of a healthcare provider that is thinking about prescribing a cholesterol tablet called simvastatin. And the patient has previously had an allergy to a different statin, and there's an alert that's come up to point out, are you sure you want to do this? And just at the bottom of the screen, you can maybe see that there's an option to override. And these sorts of alerts or flags can come in a variety of different forms, from interrupting and stopping care altogether to just a little flag or a nudge in the background. You can have a rules type decision making. So I noticed Luke there, and I was thinking when I was writing this of the Ottawa ankle rules as an example of, does a person have tenderness in an ankle? Can they weight bear? If you're finding that one of those is not satisfactory, then those are big grounds for going for an X-ray. And simple rules like that can actually add a lot of efficiency to healthcare and potentially safety. So World Health Organization checklists are used in operating theatres all across the UK for just really basic things like making sure that the right person has an operation, that we know any allergies that they have, and that we're operating on the right side and on the right organ. Sounds really basic, but lapses can happen. But models can also be more complicated, and if it's not too risky, what I'll maybe do is just provide an example of how that potentially works in clinical practice. If this opens. So a typical example, one of the top 20 admissions to acute receiving wards in Aberdeen and across the UK would be atrial fibrillation. So an irregular heartbeat, and that can lead to patients having symptoms of palpitations or pain in the chest, and that's something that you can usually help people with and get things under control. But we also have to think about the risk of stroke in folk that have an irregular heart rhythm, and so there are validated risk tools that are commonly used in clinical practice, and we use them in Aberdeen. And so here's an example. This is the CHADS-2 VASC score for atrial fibrillation. And MD Calc is one of the main websites that most people would use because it has a repository of a lot of the commonly used risk scores, but also kind of helpful information on when you might use it and why you might use it and what it potentially means. So here, for an example, you might have an elderly female patient who presents with atrial fibrillation, and let's say she has a history of hypertension, and maybe she's had a mini stroke or a TIA in the past. It may not have been for a few years, but she's had that in the past. And what starts to come out is a score with a risk of how likely it is that she's going to have a stroke within the next year. And a recommendation can be joined in with that. In some states, it may be an actual pathway or that's obligatory to follow, or it might be that it's a simple, more generous recommendation that you can deviate from. But here the score is well greater than 2, which would be considered higher risk. And so anticoagulation, so blood thinning medication to prevent the risk of future strokes should be considered. One of the things that's often not published with these sorts of risk tools is actually how they were developed, and possibly more importantly, how representative the population was that it was developed in, and how well that was performing whenever it was developed in that population or when it was validated. And just a straw poll that I did of clinical colleagues to find out if they knew much about the CHADS-2 VASC score and how good it is. None of them had given thought to, amongst my local colleagues in my own area of practice, given thought to how well it actually performed whenever it was developed in research. And for the methodologists, the C statistic of the CHADS-2 VASC score is about 0.67, 0.68 in well-representative populations. It'll probably be worse whenever it's applied in other populations. And we use it in Grampian, but we have never tried to revalidate it or recalibrate it, which potentially has implications because we're dealing with things at a population level, but of course we're also focusing on the individual right in front of us. That also needs to be borne in mind with the fact that people are not just at risk of any one condition, they're often at risk of multiple things. And a risk score that's often used at the same time in people with atrial fibrillation is almost the opposite, which is a risk of bleeding. So we're thinking about starting blood thinning anticoagulation treatment for someone with atrial fibrillation, but we're also interested in the risk of bleeding in people that are anticoagulated. We should take exactly the same patient, so an elderly patient with hypertension, and they've had some history of stroke or possible TIA or something along those lines in the distant past. And applying this different risk tool, what we come out with for the recommendation is alternatives to anticoagulation should be considered. The patient is at high risk for major bleeding. And so we've got opposing recommendations from 2 different risk scores. It's worth bearing in mind that there are other aspects to this tool. So you could get an extra point for being elderly or for having a stroke, but you could also get extra points for using alcohol to excess or having history of liver disease. So some of the risk factors seem to overlap, but of course that could depend on what risk factors were actually tested in the model. And it could well be that if you were to put alcohol into a stroke model, that it could still become relevant. And it may be that it's not in the model because it wasn't considered in the first place. You've also got to be careful then that just simply telling the person to stop drinking alcohol assumes some causality here, when actually what we're doing is we're describing predicted risk rather than a causal pathway. So telling a person to stop alcohol doesn't necessarily reduce this person's risk from 2 points to 1 point. So there are challenges, and these are day-to-day challenges that we meet in clinical practice, where we have conflicting guidance that pulls us in opposite directions, and we have to balance things as best as we can and deal with the patient in front of us. And these are challenges then when it comes to how we develop the risk tools that we might use in clinical practice. And so these are some of the pitfalls that are potentially there. Miscalibration is a common problem whenever you develop risk tools and you leave them sitting in the background without regularly updating. And one example is the Euroscore that's used in cardiac surgery, often for counselling purposes, to advise people that are going to undergo open heart surgery what their risk of mortality is. But having been developed and validated, it was left for about 10 years before it was revalidated, and it was found to drastically overpredict risk, so that people were being told about twice the risk of mortality to what was actually true of updated clinical practice. We've talked about the risk of presuming causality. There's also the risk of assuming that just because you predicted a high risk for a group of people, that the intervention that it's coupled with is going to modify that risk for all people. And then possibly one of the biggest risks is, what do you do when you have conflicting recommendations, or when it just feels completely not right with clinical practice? So where the calculator is advising you to go to in the opposite direction or a different direction to what you think. And what we would often do in clinical practice, we would start to kind of try and reverse engineer the model or tease it apart, add bits in and take them out and see if we can understand how it's working. But that assumes that every factor is contributing equally and causally, and of course that might not be the case. And once you move towards machine learning approaches, it becomes more and more of a black box, so harder and harder to do that. And that's one of the particular criticisms that's come from proponents of traditional regression tools for use in machine learning, that is there for the machine learning advocates to answer. So Flavio as a machine learner, but also open to all sorts of different tools. The ball's in your court for solving that particular problem. Acute kidney injury is going to be the example. I'm going to keep it really simple and not really talk about kidneys, other than that these are two kidneys. They're plumbed into the heart and they're plumbed into the bladder, and they filter blood and they make urine that goes to the bladder, and that's removing toxin from the body. People come into hospital with it, and it can be a cause of being seriously ill, not just while you're in hospital, but also while you go home from hospital. And there are recommendations to develop risk tools so that we can improve the way in which we plan follow-up. Most of this is currently reactive, which is the reason for the tools, but we're talking about a very broad group of people, lots of heterogeneity, and in terms of modifying outcomes, potentially opposing treatments can be beneficial in different people. So more fluid or less fluid as a typical example is starting a blood pressure tablet or not starting a blood pressure tablet. So the problem that I've given Flavio to start thinking about, and it's really still at our early stages, but at a point where it'd be really interesting and helpful to get thoughts, is, can machine learning help here to predict outcomes in a better way than we're capable of with traditional logistic regression type approaches, but with retaining explainability, and potentially is there a way of making model performance good, but also able to tailor for specific subsets of people where we may have higher or lower levels of confidence. I'm going to stop sharing my screen and Flavio, let you jump straight in.
Well, thanks, Simon, for getting this kind of background, the technical and medical background, which of course I would not be able to give you. And I think I could start and maybe with a kind of general view, and then I get into the slides. I can go through the slides very quickly and stop at the final one, which is going to contain some of the objective results we have gotten so far. So basically, I think what Simon has just shown you is what Simon has tried to explain to me, tried to make me understand from the start. And I've been trying hard to understand the subtleties of the problem. And from there, from my perspective of being not coming from the healthcare landscape, but coming from the computer science and particularly artificial intelligence view, I've been trying to bring this view to the problem. So we started, both of us, by having a lot of methodological discussion, things about how to look at it from a kind of landscape view of the problem, how to find the tensions and the issues that we would have to find and refine and then solve with the appropriate method to get to the grounds of it. And then I try to make the best of being into this field of artificial intelligence for quite a few years. So I started, as Simon showed you, a few decades ago, when artificial intelligence was a lot about logics and not so much about machine learning. Now the things have changed, and I think there are at least two tensions that we've been trying to solve when diving into healthcare issues as problems to be solved using artificial intelligence in general. So one would be assisting versus replacing. Should we provide tools to assist doctors with their decisions, or should we be so ambitious as to try to build tools to replace doctors as decision makers? So that has been around since the 50s, when artificial intelligence started officially as a field of research and technological development. And the other tension would be accuracy versus explainability. So there was a moment when I was a PhD student in Edinburgh when explainability was the most important thing. So we studied logics all the time. Even if we had to sacrifice accuracy or generalizability a little bit, if we could preserve explainability, because we would have deep explainable models based on logics, based on algebraic systems, based on everything that would explain what was going on to start with. You know, even if the accuracy, even if the performance was not so good, we would still be happy because we would be able to explain what was going on there. We would have a deep scientific model to rely on. It changed completely to the other extreme up until a few years ago. So accuracy started to matter most, and people would say, "Well, don't worry about explaining so much what's inside the black box. If it gives you the right answers, that's all we need." And then we have been moving towards this third step into the evolution of artificial intelligence now, which is, from this perspective of this tension, we can have both. So that's the field we are in right now. We would like to have models and tools which would be explainable, which would explain everything and be accurate at the same time, because we now know how to do these things. We are learning at least how to do this stuff. As for assisting versus replacing, we are more and more leaning towards assistance. So we understand in the field of artificial intelligence that good assistants are more reasonable, more sound things to do, or more reasonable goal to reach to than replacement, which was, as you see, even still today in sci-fi movies. It's still there in the kind of pop culture, and it was inside the scientific community as well decades ago. It's not like that anymore, and I think I'm going to show you the slide now, and that's going to explain maybe our view at least for why it is this way. So this is our situation. So given the specific problem of people who have acute kidney injury, they form a specific population, and we would like to know in advance what to do with them instead of just working reactively, for two reasons. One, because that's the thing to do, that's the proper thing to do. Two, because by solving this specific problem, we would learn about methodologies to solve other problems on data grounded tools and mechanisms for health to solve healthcare issues and problems. So we have these two views. So that's how we started. So we started by trying to tell exactly what we were talking about. So what does it mean to be working with data grounded healthcare? That it means that we are in this intersection of these two words, so healthcare issues and data intensive sciences. Data intensive sciences, I could try to give this mock view of it, which would be they are it relates to that approach to solve problems based on observations to start with. So you don't start with models. You start with observations. From those observations, you build observation-based explanations. And from those observation-based explanations, you build tools which are going to help you deal with the complexities of the world. When we talk about healthcare, we would imagine that at the end of the line, we would be converging. We would be in the convergence of these two views on the left-hand side, smaller rectangle there. Population healthcare issues and precision healthcare issues. As we stand now, I think we still have another tension to deal with, because they're not put together. We all understand that at some point they will be together. So when we solve completely everything with the utmost precision about individuals, we will be also prepared to talk about what happens with collections of individuals. So we will be solving precision healthcare and population healthcare at the same time. Right now, maybe it's not still the case. We are still working towards that. And because we are still not there, we have what I try to show, well, in the next slides, but what kind of problems we want to solve. The ones in the larger rectangle there, given an individual or a group of individuals or a population, we would like to know what's happening there. So we would like to be able to do right and good and precise diagnostics. We would like to know what's going to happen next, what's going to happen in the future, and we'd like to know how to deal with this feature. So, I mean, I'm sure, I mean, who am I? I'm an engineer and a computer scientist talking to you healthcare experts, but I mean, at least that's my view. That's my outside view of what the problems really are. So they are about really getting to understand what's happening, what may happen because of this that is happening right now, and how to deal with that so that we don't have to be, firemen people all the time, solving issues retrospectively. So that's the kind of thing that we would like to do. If we were really successful, that would be my next and most dear slide of the whole presentation. I mean, we would be prepared to talk about humans, human beings, past, present, and future, everybody. If we were able to do that, when the day we are able to do that, then population healthcare, precision healthcare, they're going to be put together. They're going to be there, harmonized, and all as one single view. So a new patient comes, you're going to say, I know what's happening to you exactly. A group of patients or a new epidemics epidemic outbreak occurs, we are going to say we know what's happening to every individual there. Therefore, we know what's happening with the group. Therefore, we know what to do about that. Therefore, we know where it's going to lead us to. We know how to deal with that. We know what to do right now to prepare for what's coming next. That's what we would like to get to. But we know it's, for the moment, at least from my understanding, it's still the kind of thing we would like to have, but we still don't know how to do that. So we have to find a way to get into that, to get into tools as the ones that Simon has just shown us, and myself included. I hadn't seen that before, and to get to see those tools and be able to tell exactly, yes, this is where it stands with respect to this ultimate goal of knowing exactly everything about every human being, past, present, and future. But what do we have right now? Well, we can start with. We can start with doctors, insightful doctors, and sharp-eyed medical doctors looking at their patients and getting insights out of that. And from those insights, those medical doctors can start working on hypotheses, which can then, if we adopt this data-grounded perspective, can be used to build observations based on which we are going to be able to build data-grounded models, based on which we can build tools such as the one we have just seen. And then, if we look at this very carefully, we will be able to understand up to what step, up to what level these tools can take us, so that we know with very, very well-grounded arguments why, for example, assistance seems to be more reasonable than replacement for decision making in this field as well as in other fields. So what we can do is we can start with some observable population, and we have many interesting and very useful examples of such populations from Scotland. We have all these all those programs that you have, children of whatever, of Scotland, the 50s, population generation Scotland, I remember now, all those programs which have built observation programs that have built a lot of data which can be used. But we can also think of clinical trials and different strategies to build some external view of a population which we can argue that is representative, but we should know that it's really just a very thin slice of that original population, past, present, and future, all human beings. So we have this very tiny snapshot, which nevertheless is going to be what we get. And it can be quite representative of some contextualized information about humans, about some population at least. So we start with the observable population and we say, okay, we start with that. That's objective. We can talk about those. And then we can build a model out of those. We can see if something emerges out of observations that's going to either confirm or go against that insight that we had, so that based on that, we can tell something about people that's going to be helpful for healthcare, either for the individual or for the population. Well, if we start with some population, it's still hard for us to deal with that from the data-grounded perspective, because we have to actually turn people into data. Otherwise, it's hard to get those into computers, into statistical methods, into mathematical equations to get something out of that. So from the observable population, we have to make another kind of blurring of the information that we have, because we are not going to talk about every individual. We're going to talk about, say, people as organized by age, considering years. So every 75 years old person is going to be like one individual, and we're going to put them all together as one single individual. And we are going to study population based on that, for example. And we are going to have, that large observable population is going to be turned into, I don't know, 80, 90 individuals. And then you say, well, that's just too coarse. We need to be more refined. Okay, we split into men and women. So double the population and more refined view, still too coarse. Okay, get some exams out of the people, so creatinine levels, albumin, whatever, those things, gasoline, those things. I don't know what I'm talking about, so you tell me, but you get something about the individuals, and you split those exam results in slices based on how precise your numbers are going to be, and you get more precise separation, but still conceptually it's the same situation. So you had individuals, humans out there, and now they have been collapsed into chunks of stereotypical views of people. Now we know how to deal with that, but still we need to go one step further before we can actually start to extract models out of observations, because we need to make assumptions about what we are going to get there. Those assumptions are going to be based on the initial insights, possibly, and they are going to add some constraints on our views of those data of patients which have transformed observable people who are expected to be representatives of the whole population into something else. So we transform our observations because we have specific lenses to look at people. So are we going to be talking about regression or classification? Are we going to be assuming some assumption about the shape of the patterns we are going to be trying to find? So we're going to be linearly separated. Are there going to be some other things separated? What kind of tools do we need to use, or should we employ to actually get to observations which are accurate enough to give us those both views and to solve the tension that we had initially? So they're going to give us accuracy with respect to models, to separation, to identification of what we were expecting to see or we were expecting not to see. And at the same time, they're going to prepare us to understand why certain things are happening there. So they're going to be explainable by themselves, or ready to provide explanations, or to make explanations flourish out of the observations, and at the same time useful, as machine learning tries to be. So if we put all these layers together, this is what we get. So we start with the population of human beings, past, present, and future. And then we move away from that population by looking at a thin slice of that. So observation, that trials, clinical trials, whatever. Then we get from those this organization of that to look at data from the observable population. Then we look at data from the perspective of patterns we are looking for. So what can we get at the end of it? Well, basically, all things going really well, we are going to get something that's going to tell us hints about what's going on out there with the original population we would like to be talking about. That can be published, and that can be useful for medical doctors, for clinicians in the field, because they're going to read those papers. They're going to be, updating themselves about everything. So when a new real human patient comes in, the toolbox of the clinician is going to be bigger. So the clinician is going to say, yeah, I've just read that paper with those observations. They are restrained to a specific context, to a specific methodology, but they raise the flag here. Maybe we should uh, uh, investigate that. Maybe there's something going on there. We should check that. I'm not telling you have a problem, but there is indications in the literature. There are observations that may tell us that these are the kind of things that we should look at. And that's all we can go. That's not artificial intelligence per se. We are still talking about what we would call, standard statistical methods, if there is anything like that. So statistical methods are safe ways to build well-grounded on mathematics and careful methodology, safe ways to build these very contextualized, bounded observations, which can be useful at any point. Taking for granted that the whole decision-making part is going to be still on the hands of the clinician, on the hands of the human expert out there. So when we add artificial intelligence as part of it, we start to become so ambitious as to wish to include assistance for the decision making itself, just as we have just seen. So it's not that a tool like the one that Simon has just shown us is going to tell the clinician what the clinician has to do, but it's going to advise and look and tell, look, we have been looking at data here, large portions of data, observable population, transformed into stereotypical population, and carefully crafted and organized based on patterns. And we have observed that. And in those cases, it seems that it was a good idea to do this. Now it's up to you. But, that's the observations that we have. And those observations, mind you, they are constrained to the context we have been considering. That's one step further, and it seems to be a non-trivial, big step further. But our careful argumentation here, the one that we have been building so far, is about letting people know explicitly up until what step and what point we can get with these tools, and not daring to go beyond that, because that would be methodologically flawed. We wouldn't be doing it the right way, because there's no support for that. But we can do something that's going to have support to go at least up back to the stereotypical population, which is one big step further. So that's the grand view. So it's the best so far that we have. It's still not so good, but this is what we can do. If we want to go like one half step further, we can take the stereotyped individuals and pretend that part of them are observable, part of the observable population, and parts of them are going to be part of the external population, which is not even observable. So is it the same as actually getting there out in the field and looking at people who were not there as part of the observable population to start with, who were not there as part of the stereotyped and data transformed individuals? It is not, but it can give us at least some initial idea of what we can find when we actually go out there. And that has been proven to be helpful. And even though it's not, mathematically proven, there's no theorem that's going to state that this is what we're going to, that this is what we should do for that new patient that's going to come to us 50, 100, 200 years from now, because we don't know food, how nutrition is going to be there by that time, how lifestyle is going to be by that time. We don't know about that, but we can guess, and we can guess relatively well. So that's the grand view we have right now, with all words of caution. Basically, this is what we've been working on. But in order to see whether this makes sense, and also to have concrete results which can be useful at present, we have been applying that to AKI. So just to show the kind of problems, and this is, I'm not going to talk about all of them, because I don't want to go over time. But that's the problem that Simon has just mentioned explicitly. You know, when you see people with showing certain problems, certain issues, let's imagine that we can only see the darker circles here. So we see symptoms, we see observations, and we try to connect them to decisions based on potential outcomes. And if we don't see the lighter symptom or attribute here, maybe we don't realize that these two symptoms here, they just happen very often in pairs, because there's a third lighter shaded attribute that is always there too. So because of that, these two darker shaded ones, they come together, and it may give us the illusion that they are actually, causally or somehow correlated, when in fact they come together because they are both correlated to something else which we cannot see. So is it going to work? Yes, it is going to work, and it's going to work really well within that context from where it was built. Because if context stays the same, the lighter shaded circle is always going to be there. But the moment you try to move to another time, to another context, to another population, maybe that thing is not there anymore. The correlation which seemed to be there is no longer there, and the system is going to start failing all of a sudden. So we have to know that this can happen, because that's something that we cannot avoid. We can try our best to move these lighter shaded things as far away as we can from the problems that we are trying to solve. But we have to live with that. We have to live with this risk, and tell people who are going to use the systems that we build, look, be aware. It was built this way based on those observations of that observable population, based on this and this and that. If we have all these observations explicitly considered all the time, we know that certain things can happen when we try to extrapolate our views to different scenarios, to different contexts. And then we are prepared, and we understand that those bad things or those unexpected things can happen. Okay, just put it very quickly. So this is what we've been doing. We've been trying this exercise. So let's say we get from some observable population, like the one we have at DASH, people who have had acute kidney injury, and they have been admitted to hospital, and now they have been discharged, and we want to know whether there's the risk of emergency readmission. That's important for all sorts of reasons, right? For management, hospital management issues, for healthcare, efficient healthcare issues, and so on. Well, readmission may be just too complicated, because it is influenced by external things which have nothing to do with patients, like, I don't know, available hospital beds, and how cautious that clinician who is there at that day, the day of discharge, is, and etc. So these things, it's full of non-objective observations. So maybe we could try this surrogate measure here, short survival instead of readmissions. Okay, then this is when we start getting to these views of the problems that we try to solve, which are going to lead us to building specific patterns based on which we are going to be able to build observations, which may work for the context in which we are in which we are, but maybe not in different contexts. So this is what we've been doing. We started with observation that Simon has advanced already, which was maybe we are not dealing with a homogeneous set of people, group of people here. Maybe we are dealing with a mixture of different groups of people for whom different ways of building predictions and prognostics should be used. So we started trying that. So this is the hypothesis or the insight we've been trying to check and to verify. So can we organize our initial group of people who have had acute kidney injury and have been admitted, and upon day of discharge, can we tell what's going to happen to them? Can we do it better if we organize them into subpopulations, which would be emerging from observations, given their behavior as regards what's going to happen in the future with them? Because we have those in the past, so we know what happened, the end of the story for them. So if we could do that, could we use still simple and explainable classifiers to do prognostics for each of these separate groups, and then get good results? And so that we would have a kind of two-step procedure. First, tell to which group a new patient belongs, and given that the patient belongs to that group, we can tell already many things about the patient, and we can also tell whether the patient can have reliable prognostics. And if the patient can have reliable prognostics, we can tell, decide or suggest ways to go for someone else to decide, for the clinician to decide. Well, this one should come back every 2 days, every week, or whatever, for exams, because this one is a high-risk patient. That one is okay, can come every month or whatever, because that patient is going fine. So can we get that? So these are the results that we've got so far. Well, this is the math. I'm not going to get you to all these, but basically this whole mathematics here tells us we can actually organize patients in groups, which we are calling clusters. Those clusters, I see I'm over time already. I'll try to go really fast now. So those clusters, they can tell us whether the patient is predictable or unpredictable. And if the patient is predictable, we can tell with a specific trust level what risk level is associated to this new patient. And just to show you some results, these are not actual results. They have been kind of blurred, the numbers, to keep what we get from DASH anonymous and carefully preserved there. But basically, if we could have like around 17,000 patients who had acute kidney injury. They could be organized in 4 clusters, a smaller one, which is those patients who are completely unpredictable, and another one for whom we have relatively high reliability. So accuracy in judgment is between, for example, this is the best one, 87% and 91%. And we can tell with 80% trust that accuracy is going to be within this interval. And this is the equations in the previous slide. They are things that they are the ones that can provide us with proof that this is true. So we can say, so given a new patient, new, no, sort of new, the one that is simulated as a new patient. A simulated new patient gets in, and we get age, gender, creatinine level, etc., about the patient, and that patient is classified as belonging to cluster 3. We go there and we say, yeah, cluster 3, those are the ones that are predictable ones. So let's use the predictor, and we say, and the predictor gives us low, low risk. So low risk, and the patient is then verified as truly being low risk. That would be a happy ending of the story. Okay. Patient number 3 would be the other situation. Cluster 3, same thing. They apply the predictor, high risk, and the patient indeed died before 90 days. So it's okay if that patient here, or he in this case, if he had been classified as high risk, because that would give him the appropriate follow-up. And patient number 2, young patient, male, we apply the classification, and we realize that this patient belongs to that group, the bad bean ones, as we've been calling them, the ones for whom prediction is impossible. So we don't try to predict anything. We just tell, since we cannot tell what's going to happen to you, we're going to give you careful follow-up. So as if it had been classified as high risk. So in this case, that would have been a mistake, but in many other cases, it would have got right. But it seems to be the right thing to do, because that's the unpredictable ones. So this is the kind of thing that we've been doing in practice as a response to the methodological discussions we have been having so far.